Now we'll hear from Grant Baldwin from the Centers for Disease Control and Prevention, and he serves as the director of the newly created Division of Overdose Prevention, where he helps lead CDC's response to the prescription drug overdose epidemic. And it's very timely that we have him here today because you may have seen yesterday CDC just released new guidelines for clinicians who are considering tapering patients' opioid prescriptions. So we're just delighted to have you. Grant is a longtime leader at the CDC and a national voice on injury prevention. Grant has always impressed us by his passion and dedication to improving the lives of Americans. And in fact, we've enjoyed working with him several times with you and your team. You've got a terrific team as well. Grant is here to share the CDC's ongoing work in responding to the opioid crisis, and we're delighted to welcome him to the podium.
Well, thanks so much, Nancy. It is an honor and a privilege for me to be here. You know, opioid overdoses should be never events. They should never happen. If we have a society and a system of care and supports that protects us at every turn, for those who have an opioid use disorder, that means increasing access and availability to naloxone, that opioid overdose reversal drug. It also means increasing access and availability to medication-assisted treatment, which is the standard of care, plus the wraparound services that we know are absolutely essential for long-term recovery. For others, this means continuing to attend to the problematic opioid prescribing, more aggressively dealing with the illicit opioid landscape. I'll talk at length about that. And addressing which is really the focus of today's conversation, the upstream drivers that put people at risk for opioid misuse, abuse, and overdose, those contextual and life course factors. So as was mentioned, I'll talk about the historical trends, how we got here, and then I'll focus the bulk of my remarks on CDC's prevention and response activities. So drug overdoses in this country have never been higher. We've lost over 700,000 of our fellow Americans, 700,000 since 1999. This includes over 70,000 in 2017 alone. That's 190 people per day. This is a time series map showing county-level drug overdose mortality shifting between 2003 and 2017. The growing abundance of red showcases an epidemic that really continues to worsen. So in those 70,000 deaths, we know that 2 out of 3 of those deaths are opioid related, and now 2 out of 3 of those deaths are illicit opioid related. So when you think about the opioid epidemic, you need to think about it in 3 distinct but overlapping and reinforcing waves. First, beginning in the late 90s, 1999, with an increase in prescription opioid-related deaths, then a surge in heroin-related deaths, and finally, an exponential increase, a skyrocketing of deaths associated with illicitly manufactured fentanyl and fentanyl analogs. Fentanyl is 50 to 100 times more potent than morphine, and some of those fentanyl analogs, like carfentanil, is 10,000 times more potent than morphine. It's actually used to tranquilize large game animals. As was mentioned, the impact of the epidemic is so pronounced, it's influencing U.S. life expectancy. The only thing I'll add to what was said earlier is that 3-year decline in life expectancy, the last time the U.S. has had that was the 1918 flu pandemic. And now opioids are nested in a broadening drug overdose epidemic driven by psychostimulants like cocaine and methamphetamines. From 2010 to 2017, death rates involving cocaine and other psychostimulants like methamphetamines increased 230 and 430% respectively. Opioids were involved in over 70% of cocaine-involved deaths and 50% of meth-involved deaths. So the rise in cocaine-involved deaths is largely co-occurring with opioids, but the increase in methamphetamine deaths is happening with and without opioids. So when I travel the country, I hear, yeah, we have a huge opioid problem, but we also have a huge meth problem. So the original title I was going to use for this slide was, "It's fentanyl, fentanyl, fentanyl." This is data that we released just a few weeks ago that looks more holistically at all drugs involved in overdose deaths in the first 6 months in 2018 from 25 states using data that CDC collects. Note that 2 out of 3 of those deaths, highlighted with the arrow, now involve fentanyl. A third of those deaths just involve fentanyl with no other illicit opioids involved, so that means fentanyl alone is a problem now. And finally, just 17% of deaths were prescription opioid alone, and deaths from prescription opioids are actually continuing to decline. So that's the good news. The bad news, unfortunately, is that those improvements are being offset and outpaced by deaths involving fentanyl. And over 60% of suspected fentanyl deaths include either cocaine, methamphetamines, or benzodiazepines like Xanax. So we're also seeing an increase in the number of fentanyl deaths west of the Mississippi that we weren't seeing before. That's something that we're obviously very concerned about. At the outset of this epidemic, those most impacted were white, rural, male, and between the ages of 25 and 54. But now, as I say on the title of this slide, it's really an everybody problem. Between 2016 and 2017, opioid overdose deaths rose for men and women, all races, and for persons, all people over the age of 25, with particularly striking increases in deaths among African Americans, those over to the age of 65, and deaths in urban areas, which we think all of those trends reflect the illicit fentanyl marketplace permeating other drug supplies. And it's an everywhere problem. So it's not just in Appalachia and the Midwest or the Northeast. Between 2013 and 2017, the number of opioid deaths in the United States nearly doubled from around 25,000 to over 47,000. And a total of 35 states saw statistically significant increases in their drug overdose death rate. Just for context, to put all of this in perspective, in 1999, there were 8,000 opioid deaths. So how did we get here? First, pain was designated the fifth vital sign, and chronic pain was increasingly treated with opioids without a clear indication that opioid use, the benefits of opioid use outweighed the risks. Second, there was an underappreciation of the addictive potential of prescription opioids. There was a limited literature with very serious methodological flaws that mischaracterized the risk of addiction at less than 1%. Third, there was very aggressive marketing of these drugs to clinicians. Purdue Pharma, the maker of OxyContin as a specific example, spent over $200 million on marketing of OxyContin in just 2001 alone, and they made at its peak $3 billion in 2013 on the sale of that drug. Fourth, rogue actions by clinicians who ran pill mills that profited from overprescribing. Pill mills are typically cash-only operations where nefarious doctors prescribe at will with very limited physical examination. And the last couple are associated with the illicit opioids. Sophisticated actions of drug traffickers that opened new heroin markets that made it just as easy to get heroin as it is to order a pizza. Think of the power of the smartphone. And finally, the perfect storm that is illicit fentanyl that makes it highly sought after because of its potency, but it's also easy to make and traffic while generating very, very astronomical profits for drug traffickers. Just as a point of reference, you make 20 times if you traffic fentanyl what you do if you trafficked heroin. So what is our North Star? What is CDC doing about it? Our North Star, this is what guides everything that we do, all decision making, all investments, is to prevent opioid overdoses and deaths now, as well as attending to some of the upstream drivers that put people at risk for substance misuse, abuse, and overdose. But there really is an urgency of the now, given the data. We have 5 strategic pillars. They are to improve data quality and track trends, to strengthen state, local, and now tribal capacity to scale up evidence-based programs, to improve patient safety by giving clinicians the tools, resources, and guidance that they need, to strengthen the relationship that we have between public health and public safety, especially because of the illicit marketplace, and to link people into treatment, and finally, to empower the public to make safe choices. I'm going to talk for the rest of my time at the podium about how we're implementing each of those 5 strategic pillars. So this is a map of the 66 funded jurisdictions who are now part of our Overdose Data to Action Cooperative Agreement, 47 states, 16 large cities and counties, DC, Puerto Rico, and the North Mariana Islands. This integrates all of CDC's state-based funding into one announcement and is about using data to inform better prevention and response activities. The scope, the scale, the complexity, the urgency, and frankly, the ambitiousness of what we're hoping to achieve have all grown in recent years. And that's why you see a broader array of prevention activities supported by CDC, again, with a focus now on the partnerships between public health and public safety, as well as trying to link people into care. Overall, states will receive anywhere between $2.3 and $7.5 million in support. Let me mention just a couple of things, both on the surveillance side and on the prevention side. So on surveillance, our credo is more timely, more localized, more actionable data, and to create data that is sought after, easily accessible, and readily used. We do this both for morbidity and mortality. On the morbidity side, we use syndromic data from folks having a non-fatal overdose who visit an emergency department, and now we're going to have those data at CDC within 2 weeks of the overdose event. And the mortality side, we're also collecting more timely data, comprehensive data with all the key risk factors, and frankly, all the drugs on board at the time of the death. We're also supporting innovation as well. You see that at the bottom of the slide. So for example, why not test drug paraphernalia in syringe that's dropped off in syringe service programs to understand how the drug marketplace is changing? So that's what some of our states are doing. And there's a whole variety of activities that they're enabled to do. On the prevention side, I'm just going to talk about one of our prevention components, and that is to how we can better enhance and maximize the use of prescription drug monitoring programs. So we're trying to incentivize healthcare providers to use PDMPs, integrate PDMP data better into clinical workflow through EHRs and other means, and giving clinicians clinical decision support tools that make it easy for them both to use and find utility in PDMP data. So for the first time, CDC funding is going directly to the hardest hit counties, cities, and communities. So in addition to the 16 jurisdictions that I mentioned earlier, the New York, Chicago, Houston, Phoenixes of the world, 20% of the prevention dollars that states receive have to go through mini grants and subawards to communities that are particularly hard hit. So we're really proud of that. This graph, or this chart, is really an outline of the kind of coordinated activities that we at CDC think need to be in place. So for example, local health departments can use emergency department data to alert a community of a surge in an overdose, or EDs can provide naloxone to high-risk patients to prevent future overdoses, or link those patients to mental health and substance use treatment services. Public safety and law enforcement can identify changes in the illicit drug supply. And finally, community-based organizations are often best able to mobilize community responses for those most at risk, like some of those essential harm reduction services. So again, it's in an integrated and braided web of services and supports. As I mentioned, CDC funding is going to tribes for the first time. We are funding 11 tribal epicenters with a total of $2 million each year for 3 years. And you see the epicenters listed on this slide to provide technical support to tribes and other key partners on data collection, use, and data sharing. As important to me personally, we're also giving $10 million each year for 3 years and funding 15 tribes across the country to implement proven prevention and response protocols, basically replicating what we're trying to accomplish with overdose data to action. As I mentioned a couple of times, we are working eagerly to try to strengthen the partnership between public health and public safety. And one signature program is the Overdose Response Strategy. This is a partnership between CDC and the Office of National Drug Control Policy and their High-Intensity Drug Trafficking Areas program. The goals of ORS are fairly straightforward, but they include to coordinate data sharing better between public health and public safety, and to develop and support and implement evidence-based prevention programs. Given some of the success and frankly the inventiveness of the program, we're looking to expand it. We're going to add 6 new states this year, and we're hoping to go nationwide in the not too distant future. Here's another example of an innovative partnership where we're trying to spur innovation. We're co-sponsoring this initiative. It's got a terrible acronym, but it's a fantastic program. This is the Kuechly Program, which stands for Combating Opioid Overdoses Through Community-Level Intervention. It is innovative and evidence-based and community-led, and examples that you see here listed on the slide. So like post-arrest diversion to treatment for folks with an opioid use disorder in Kingsman, Arizona, on-call coaches and referral to treatment within fire departments in Providence, Rhode Island, and the expanding of access to MAT within the Cuyahoga County, which is Cleveland, their jail system. So the goal moving forward, as was mentioned earlier, is to scale up these programs, and so we're aiming to do that. You heard earlier from Don and others about the power of ACEs, so I'm going to largely skip over this slide, but I think the graphic tells a story about how some of those adverse societal conditions play out in the context of adverse childhood experiences and ultimately impact those diseases of disconnection and despair. This graph shows specifically the association between ACEs and a whole variety of health outcomes, but I focus in, not surprisingly, on the impact on drug use. So somebody with an ACE score of 5 or more is 6 times more likely to ever have a drug problem. So obviously part of attending to the opioid epidemic means addressing ACEs at a very societal level and assuring that safe, stable, nurturing relationships and environments are in place for our children. We will be releasing, I'll flag for you later this fall, a Vital Signs, which is one of CDC's monthly publications that's focused specifically on ACEs, so please look for that. One particularly innovative project, it's also a Kuechly, is called the Martinsburg Initiative. It's focusing, it's implemented in a small town in the eastern panhandle of West Virginia. It's a police, school, community partnership spearheaded by the Martinsburg PD, the Berkeley County School System, and Shepherd University, as well as the Washington-Baltimore HIDA. It focuses on ACEs to create trauma-informed community working together to build resilience for their children. It's a tiered program that includes both universal supports that benefit everybody in the community, as well as targeted prevention programs, and then those wraparound services for those kids and families that are in most need. So again, it's both a primary prevention and trauma-informed care. Just a couple of more programmatic examples. This is ODMap. This is a cutting-edge tool that can identify hotspots and potentially provide outreach and connection to services. This was started in March of 2017 by the Washington-Baltimore HIDA. What you do is you geocode at the location of a fatal or non-fatal overdose where that location is and whether or not the naloxone was administered. So for our part at CDC, we're working with the Bureau of Justice Assistance to fund 8 states to implement ODMap statewide and to try to highly improve coordination between public health, behavioral health, and public safety. So what if every month anyone and everyone who had a leadership role in your community to address the opioid epidemic, from health to law enforcement, from behavioral health to prisons, from housing, to just about anybody you can think of in a community, what if they came together to discuss the trends and to review a number of cases about looking for gaps and opportunities to improve outcomes? That is the RXSTAT program. It was started in New York City in 2012. It's not just your typical fatality review, because everyone has agreed to that overarching goal of what is going to reduce overdoses now, and there's a mandate to innovate, rapidly test new strategies, and follow up to determine if they're working. It works because everyone is held accountable to that large outcome. So we're investing in the expansion of RXSTAT. We're funding a best practices toolkit and piloting it in Pennsylvania, thanks to the support from Bloomberg Philanthropies. And now this is, I think, what Nancy was really eager for me to talk about. This is some of the work many of you have probably seen. In March of 2016, we came out with CDC's opioid prescribing guidelines for chronic pain, for primary care clinicians outside of active cancer, palliative, and end-of-life care. Those guidelines are not a rule, regulation, or law. They are simply intended to inform clinicians' discussions with patients and their prescribing decisions based upon the best available evidence at the time. This slide shows some of the translation work that's happened to date. I will talk at length in the Q&A if you'd like about some of the others, but this specifically is, I think, where there's some energy. We came out, part of our translation efforts the author guidelines published a commentary first in the New England Journal of Medicine in April, where they addressed the misapplication of the guidelines. Specifically, some policies and practices purportedly derived from the guideline were in fact inconsistent with and went beyond its specific recommendations. This included no longer providing treatment for patients on long-term opioids or abruptly discontinuing patients from their opioid prescriptions. It may also mean aggressively tapering folks where it's not warranted and potentially leading to bad outcomes. So there was also some sensitivity around that those cautionary thresholds that CDC had in our guidelines, the 50 and 90 morphine milligram equivalents, were mandates for hard stops, and that was obviously the case. So this commentary was a preview for ultimately a document that Nancy mentioned came out yesterday, which is a tapering guide, showcased that there are really no shortcuts to safer opioid prescribing and that individual patient situations and care needs really need to drive practice. We're in the process of determining whether or not an update to the guideline is necessary, and we'll be making that decision very, very shortly. But did want to call your attention to that tapering guide that was released yesterday, that although information around tapering was included within the original CDC guideline, we wanted to, HHS more generally wanted to bring it more top line, and so really excited about that resource being out there. And finally, I wanted to share with you how CDC is making a priority to raise awareness about the risks of prescription opioid use and opioids more broadly. We launched a communication campaign in September of 2017. It's based on the past success of other testimonial campaigns. You may have seen the Tips from Former Smokers campaign. This sort of takes a page from that playbook, people who have lost loved ones to the opioid epidemic or are living in recovery, them telling their story. It's a very successful campaign, 175 million impressions across multiple channels. A huge volume of people visiting the CDC website and resources, so please check it out. Obviously, we need to end stigma and lift each other up and not shame each other down, individuals, families, communities. This is CDC's effort to do that. It's my last slide, and I wanted to close on an optimistic note. Obviously, the challenge before us is daunting and overwhelming. And sometimes feel like the end game is constantly shifting, and that's fair because as you saw with the data on fentanyl, because it actually is shifting and changing. But we've been bold, and we can continue to be bold, and with determination and persistence and resolve and courage and some openness, I have a great deal of confidence that collectively we will ultimately turn the tide on this epidemic. Unfortunately, because of those skyrocketing fentanyl deaths, I think we lose sight of some of the progress that we have made. So I'm going to end with a quote from Nelson Mandela. He said, "It always seems impossible until it's done." And together, I think we can get it done. So thank you very much, and I look forward to the conversation.